Welcome to Black Health Matters. I'm your host, Daryl Armistead. This is a Howard University Hospital transplant support group session led by Dr. Clive Callender, who is a noted transplant surgeon and professor of surgery at Howard University College of Medicine. Let's join today's session in progress.
The black population is lactose intolerant, but for those who are not lactose intolerant, it appears that milk does not affect your cholesterol level one way or the other. So that those of you who can drink milk uh, or butter can recognize that it's not going to hurt you that much. That's the summation of the article on milk that the most recent studies demonstrating that the fat content is not going to be the problem. But if you're black and you're lactose intolerant, there's a lot of other reasons why you should leave milk alone.
Hi.
Uh,
Good morning, Shami.
Good morning. How are you?
the other article is about something that we've long known, and that is that physical activity. Well, it documents the fact that the more you exercise, that the exercise actually kills off the cancer cells and causes this cancer cells to stop growing. So it points out that uh, exercise, and particularly resistance exercise and weightlifting and those kind of things,
He went up this article
cause the
thing.
promotion of things in your blood.
Yeah,
It
the
actually
view.
kills cancer cells. So, uh,
Is in
so anyway, that's information that I wanted to share this morning. Any comments or question about that information?
Yes. Good morning, Dr. Callender and everyone. Yeah, I thought it strange that my father was lactose intolerant back as far as I can remember, and I'm not. So I was just wondering, is there a major genetic uh, predisposition uh, for lactose intolerance?
Yeah, apparently there is. I'm not exactly sure what it is, but for example, I'm not lactose intolerant, but my wife is, and my children are. All my children are. So yeah, there's a genetic transference that has to do with lactose intolerance. But Daryl?
Yeah, I think you said a third of the population is lactose intolerant. Is that what you said earlier?
Approximately a third of the population, mostly uh, African Americans, probably more than that, but the third of the population, but that's because most of the population is Caucasian. Yeah.
Yeah. Internet says that 80% of African Americans are lactose intolerant.
Yeah. Okay. Right. And for that reason, that's a good reason for you to avoid both projects, particularly if you're lactose intolerant. Their data is for those who are not lactose intolerant. Any other comments or questions about that? Thank you for sharing, Daryl, once again. Okay, let's go with the articles. I have to leave early. This probably 9:25 today. I have to go to see the doctor. This is an article about the pig lung transplant, which is kind of deceptive in a way because this is a brain dead adult person who received the pig transplant and had some evidence of rejection, which was treated. So it's not a walk in the park. It's this is a pig to human lung transplant, the first of its kind. It was done in China and hasn't been done yet in the United States. And as we know, the uh, pig kidney has been done, and the pig lung, and I mean pig heart, and all of the pig hearts have died subsequently, and only one of the pig kidneys is still working. But this year we're going to have a series of universities that are going to be involved with studying pig kidney transplants to see if it's time to make them in the same uh, situation as human kidney transplants. Uh, they will be experimental and they'll be studied for the next year or two with FDA approval. So, with the hope that the number one problem in transplantation, which is the shortage of donors, is 103,000 people on the transplant waiting list, and 13 people die every day because of the shortage of donors. And so, this is the reason why efforts at increasing donation in humans and using the pig for xenotransplantation have now become something that is important. Of course, from a positive perspective, when I over the last 10 years, we've gone from 25 people dying every day down to 13 dying every day, which is progress. But we want to get it to the point where we have none dying every day because of the shortage of donors. Any comment or questions about the significance of this pig to human lung xenotransplant? Dr. Perez, welcome back.
About good morning, everyone. Missed you last week. What percentage would you say of the research is financed from the government to the advancement of the kidney? Do you have
You broke up, so I couldn't understand your question. Could you repeat it, please?
percentage of the research on xenotransplantation of the kidney that is funded by the government?
Well, all of it, well, of course, I don't know because I really don't know the answer to that question. What percentage is funded by the government? Because we're talking about NIH again.
Funding.
Yeah. Well,
Okay.
unless you're talking about, you see, you're talking about research, correct?
Correct.
Yeah, that'll all be done under the auspices of NIH. And I don't know the answer to that question. Whatever it is, you know
Okay.
it's going to be reduced. But anyway, uh, but I don't know. I really do not know the answer to that question. And all of this xenograft transplantation would actually be experimental, so it would not be paid for by insurance companies until it is deemed not experimental. Any other comments or questions about this new development that uh, is threatening to become more common? Generally speaking, the pig transplants are done for those patients who have antibodies to humans and therefore cannot receive human transplants. Uh, and that's just as probably about 10 to 20% of the population who are on the waiting list. John Buchanan?
Yes, Dr. Callender, what is edema? It said that
Swelling.
swelling. Okay,
Swelling, yeah.
thank you.
Okay. We'll go to the next article if there are no more comments or questions. Now, this is the real deal this year. This flu season is the first where we're having a new Secretary of Health, and we have new reasons for many of the different vaccines. But one of the things we do know is that with the flu vaccine that we do have the high dose and we have the regular dose. And if you're over 65, you should not accept the flu vaccine that is not specifically for people over 65 because it's a higher dose and your immune system at 65 is not as potent as those who are under 65. Now this talks about the things that you may get with the flu vaccine, although most of us have nothing. But you can see these numbers that show that less than 20% have many of these symptoms, and they resolve over a day or two. But I think the thing I want to emphasize is to be sure that you get your double dose flu shot, not the regular dose, the double dose for 60 and over. And there are other articles that point out that this reduces the hospitalization and the need for hospitalization if you get the flu. Uh, while there's a lot of question about the availability of or when you can take the COVID vaccine for the flu, there's little doubt that uh, everyone should be vaccinated if you could. There was a recent study that said that 1 out of every 6 patients is going to uh, be vaccinated. So 5 out of 6 will be vaccinated. 1 out of 6 will not. So please be sure if you're 65 or over and you're going to make sure that you request the double dose and so you don't take the other dose. The high dose is very important. Plus older people whose immunity has waned. Any questions or comments about the flu vaccine? Because the other question is when should you take it? And most of the evidence suggests that taking it before the end of September is not advisable, but uh, taking it at the end of September and later is much better because you got a good 6 months of potency. And so taking it before September is not advisable, but taking it toward the end of September and the beginning of October is very, very advisable. Any comments or questions about the flu vaccine? Okay, well, it's very important to recognize whatever issues there may be about the COVID vaccine, they apply to those people under 65. And when you're 65 or older, then the COVID vaccine is recommended as well. This is a study that demonstrates randomized trials that high dose flu vaccines reduce hospitalizations. We've talked about this on a number of occasions, and I've always suggested that you need to get the high dose. And if you got the low dose, go back and get the high dose. And this is just confirmation and proof. Although there's studies in the different countries, the bottom line is the same, and that is that the people who are over 65 and have the lowest immune responsiveness are less likely to get pneumonia or get hospitalized with the flu. And this is important. So when you go out, be sure to get the high potency flu shot. If they don't have it, go to another pharmacy that has it. Any questions? I can't see any hands. But so the COVID and the RSV virus are also recommended, but it's expected that the RSV vaccine can be given annually, but there's evidence that it may last the longest 2 years. Any other questions, comments? I think there's been some confusion about whether or not you should get the COVID vaccine. But if you're over 65, it's approved for people over 65 and other high risk reasons. But those people who are 50 and under, that's another issue. But for those of us who are 65 or older, that's been confirmed that it's approved for you. The best time to get question? Is there a question?
No.
Was there a question? Couldn't hear the question. Is there a question? Okay. Well, this is the article that talks about the best time to get a flu shot, and the best time to get a flu shot is the end of this month, around this time. And the summer season in August, of course, is too early. But now's the time. Towards the end of September, the flu season starts probably in late October, November, December, January, February. So now's the time to get a flu shot. Most people think, yeah, it's early.
As part of my physical last week, the doctor wanted to give me a flu shot, but I remembered what you said, not quite so soon, to wait in October, and I've always gotten it in October. So I told him I'll just come back in a few weeks to get it.
You get a double dose, be sure.
Yeah. Mm-hmm.
Yeah, I also scheduled mine for, I think, October the 2nd.
Yeah.
Getting mine in October.
Okay, good. All right. The question of how long does it last? That's a good question. Most people will say it's certainly good for 6 months. Beyond that, it probably starts to wane, but a good 6 months. And by the end of the 6 months, the flu season is over. So you get it in October, that's pretty good. Now, the new sequential new pneumococcal shots are beneficial for older folks over than 60 as well. And the randomized control studies have suggested that they're worthwhile taking if you haven't had them. And all of the studies that they've done have demonstrated that they're effective at preventing pneumonia, which of course is a common cause of death for people in over 65. This is a relatively new pneumococcal vaccine, which is apparently more potent than the previous one. Yes, John Tatum?
Yeah, can they be taken together? Can they be taken at the same time?
What are you talking about?
The flu shot and the RSV.
I think the flu shot and COVID can be taken at the same time. I don't know about RSV. I know studies have been done on the flu shot and COVID, and they can be given at the same time, but I'm not sure about RSV. Any other comments or questions? Okay, let's go to the next article then. This is an interesting article that suggests that there's an over-the-counter nasal spray that has been demonstrated to be effective for uh, potentially preventing COVID infections. I don't know anybody who's ever used it, but these studies indicate that significantly lowers the infection rate. So I wouldn't recommend doing it in place of, but it's just to be knowledgeable that this is something that is over the counter that can help prevent COVID-19.
Dr. Callender, do you know the cost of this?
No, do not. But it's over the counter, so it can't be that expensive. Okay, let's go to the next article then. And because of the uh, new Secretary of Health and all of the controversies, uh, this article becomes something to be aware of that. But keep in mind that if you're over 65, it is approved for you. But if you're under 65, that's a lot of confusion. Oh, maybe I can't communicate. Yeah, so maybe you can put whatever question you have in the chat.
She's on two devices, Dr. Callender, and one of them is causing the feedback. So you need to cut one of them off. The stand one, one of them. Betty.
Okay. But it's important that we understand that much of the controversy does not involve people who are over 65 because it's approved for us. It's the people under 65, people 50 and 40 and 30 and the like that there's some controversy about it. And there have been a number of people who have wanted to get the COVID shot, but in the District of Columbia, they had difficulties. But that should not be for the person who's over 65 or has high risk. Any comments or questions about this? Because this is important to understand so that you do not fail to get the COVID-19 vaccine when it's approved. Is there any questions? Anybody?
Well, it's something that I think this group is real important for, and that is the fact that we now have multiple generations living together, and the risk, especially, we're expecting today a new recommendations for childhood immunizations and their schedule, but knowing that the risk that young people, the age groups that are not approved for vaccination, have, um, at the beginning of the epidemic, we know the impact that it can have, especially with those strands that are very contagious with an older generation. So I think it's important that we be advocates for it. Many states have gone away with the recommendations associated with the federal government and are now having their own standards as it relates to COVID. So it's important for us to be advocates for that moving forward because we know that the research is not going to come from the federal government on those issues.
Well, I think it's a very good point because you're right. Gener It's intergenerational, and we have families where multiple generations live together. So it does cause confusion and susceptibility for uh, the different populations living together.
Yeah, case in point, directly to that, I just heard of a family that sent their child to school and the child tested positive for COVID. And every family member, the father, the mother, the younger, like a 2-year-old got it. Everybody in the house got COVID. So it hasn't gone away, and the masks and everything are gonna probably come back, I think, because people are just being casual about it. Thanks.
Thank you for sharing. Okay. Sorry about the communication problems that some of you are having today. And, there are no other questions. We'll go on to the next article. This is an interesting that I think Dow brought out the point that some of the medications are cheaper in other countries, and Trump has a plan to lower the U.S. drug prices and raise them in other countries. Interesting. Uh, Whether that will work or not remains to be seen. But this is going to be interesting to see what it says, because it is true that in Canada you can get drugs cheaper than you can in the United States, and which suggests that our prices are higher than other countries, generally speaking. So it's going to be interesting to see if I think there have been thousands of letters written to pharmaceuticals recently to try to get them to lower their prices. What will happen remains to be seen. John, you think?
I'm sorry.
Oh, okay. All right. Any other questions or comments?
Yeah, Dr. Callender, what time did you say you have to leave today?
9:25.
9:25?
I'm sorry, 10:25.
Okay, thank you.
10:25.
If
Okay.
someone still has two devices connected, you need to mute one. There we go. There we go.
Okay. Any other questions or comments? We have to wait and see what's going to happen with this. Uh, it's very desirable that the drug prices be reduced if possible. Okay, let's go to the next article. Yeah, this is as Dr. Perez had mentioned, many states are ignoring the federal guidelines and are coming up with their own guidelines for the vaccinations because they're not agreeing particularly with the COVID recommendations. And as such, you need to check with your state guidelines and see uh, so you don't have to rely solely on the federal government for COVID vaccination because the states have decided to do it differently. Virginia is for one, Maryland also is different as well. Because while the district has been ambiguous about it, uh, Maryland and Virginia have not. They've been making it access to the COVID vaccine as easy as possible. Okay, let's go to the next article if we don't have any comments or questions. Yes, this is an article that people have been waiting for, that that there's some child deaths and we're waiting for the data to allow to be reviewed by the scientists to decide what kind of link there is with the COVID vaccine to deaths in children. Uh, it appears that uh, that there are situations where in younger children the deaths from COVID may not be as great as the deaths from adults. And so we wait for this data to come out so we can look into it and see how we can best administer the COVID vaccine. And I think it's interesting. Why would you say we're going to release it in a couple of weeks if it's so important? Why not release it now? But anyway, but this particularly involves COVID vaccine side effects in children, which uh, 10 million children. So it's interesting to see how many of the children actually had those results. So we'll await the data to see. So it's best not to be biased, but just wait and see what the data shows. Although you have to wonder why you're waiting to release the data if it's so important.
Which I think Dr. Callender speaks to the validity of the data and information that gets released. I mean, come on.
Yeah,
We even had a few minutes with our secretary when he was investigated by the Senate. Boyfriend is clueless.
yeah. Well,
And people were fired because they refused to do what he said.
well, yes, many.
We're living under a dictatorship.
Well, yeah, that's no surprise. They voted him in because he's a dictator. So, I mean, what do you expect? Yeah. And now they're angry because he's the dictator he always has been. So, it's kind of hypocritical. That's his very nature. Okay, let's go to the next article unless there are other questions. Now, this is an article that just points out the five things that we should be aware of. And although colonoscopy, of course, is the gold standard, it is invasive. And we now have more non-invasive screening and diagnostic tools. As you know, stool DNA tests, even blood tests, uh, looking for RNA markers and DNA markers. And the blood and are the non-invasive tests that are expanding to make an earlier diagnosis of colon cancer, although we don't have all of the data yet on those things. But that's one thing to be aware of. And second is that minimal invasive surgical techniques in terms of laparoscopic approaches and those kinds of things make the surgery for colon cancer uh, uh, to be associated with less morbidity. Uh, uh, so that's number two. And then number three, genomic profiling of the uh, cancers enables us to identify what kind of treatment is best for the particular cancer that you identify. And this is something that is relatively new. And precision oncology, of course, which is state of the art today, uh, based upon genomic profiling, is something that is very much desirable. Then, in addition, we have a number of ways of targeting the treatment of metastatic colorectal cancer. We even now do liver operations on people who have liver metastases as long as they're uh, limited to one lobe or and so this is relatively new that metastatic liver cancer, for example, can be excised now, which wasn't the case earlier. And then finally, immunotherapy has been able to be associated with durable responses. And so those are the 5 things that are important to know about colorectal cancer, which is affecting younger adults nowadays. So that we have it at 45, but it could be lower. And so whenever you have any symptoms of colorectal disease, whether it's blood in the stool or change in bowel habits, before the age of 45, then that's a good reason to consider colonoscopy and these other tests that can help identify early colorectal cancers. Any comments or questions about colorectal cancer and its treatment? The fact that some of this immunotherapy can avoid surgery, radiation, and chemotherapy altogether is remarkable. So we're approaching the era in which we have genomic changes as well as AI changes that are affecting all branches of medicine and surgery. Any comments about this? If not, this is goes along with the article that I talked about in the Washington Post. Exercise may not only help prevent cancer, but fights it at a cellular level. And they pointed out in the article in the Post how that when you weight lift, they tested your blood before you exercise, tested your blood after you exercise, and they showed that after the exercise session, your blood is killing cancer cells or slowing it down, which is evidence that exercise is good for many things, and especially for cancer. Any comments or questions for those of you who don't exercise? I'm sure most people on this people who are here today exercise because I think once you reach the age of 40, exercise becomes mandatory.
I had a question for Daryl. What is interval training? What does that mean?
Oh, interval training. I think they talked in the article about the general exercises that we do, the 150, the daily exercises that don't have to be intensive, but I think that when they talk about interval training, I think that's what they're talking about, intensive training. Dal, did you have any other idea on the interval training? They did mention that also in Washington Post about but they claim that the blood was drawn after a single training session, and they therefore concluded that the more you exercise, the more your blood decreases or eliminates the cancer cells.
Yeah. The interval training, I'll give you an example. For runners, that could be like a sprint, short sprint, anywhere from 60 to 100 yards. Then you walk back to your start point and do it again. That's one example of interval training. when you're, let's see, when you're doing weight training, and an example of that can be what they call supersetting. So, okay, typically when you're not doing interval training, when you're doing weights, you might do 3 sets of a particular rep. It may be bicep curls. You do 3 sets of 10. But when you superset, that's part of interval training, rather than doing 3 consecutive sets of repetitions, you'll go from one exercise to another. So you'll do, like, say, 1 set of bench presses, and then you follow that with 1 set of bicep curls, and so that you're mixing weight exercises. You're not doing them consecutively. That could be, um, uh, let's see, it could be, if you're doing upper body, that could be bench press, bicep curls, and lat pull downs. That's a good super set for interval training when it comes to weights. Does that do it for you, John?
Thank you very much.
Okay, if there are any more questions or comments, this is a very interesting confirmation that exercise helps. This is a great article talking about the fact that people who smoke get cancer, but people who don't smoke get cancer from people who smoke. And all of us have lungs, so we all can be victimized by those people who smoke. Yeah, the lung cancer is more likely in a person who smokes, but it also can impact us. And a significant number uh, uh, of people who were not smokers develop lung cancers. And so we have to keep in mind that if, for example, if you're married to somebody who smokes, or if you're in a room where a lot of people smoke, that your incidence of or likelihood of getting lung cancer is increased. And so they therefore think that getting lung screens, even though you're not a smoker, may be a good idea so that you can make an earlier diagnosis, because the earlier you can diagnose the cancer, the better you're able to treat the cancer. And the more likely it is to be curable if you get an early stage of lung cancer. And so the lung screening, which is associated with a lower uh, radiation dose, is increased if you have an early diagnosis. So chemotherapy and immunotherapy have been able to decrease the or increase the lung cancer survival rates. So an earlier diagnosis, so even those of us who don't smoke could get lung screens that might pick up cancer early, particularly if you're around people who smoke. Any comments or questions about this article? Okay, I'm sure all of us have been exposed to somebody who has died of lung cancer or breast cancer. So this is an article that talks about 5 things that we should be aware of as it relates to lung cancer. We already know about uh, the fact that smoking, of course, is the commonest cause of it. The fact that the increased incidence of cancer in the non-smoking population becomes important. Uh, so, and the fact that we have multiple ways of dealing with lung cancer now, with surgery, also And they talk about first thing is that it has a lot of different types of lung cancer, which are treated differently depending upon whether it's locally, regionally, or metastasize if it has already metastasized. And there are a number of types of lung cancers, and all have different ways of approaching and attempts at curing it. Um, this is probably among the most important things to recognize, that we now have low-dose CAT scan screening, which allows for early detection. This is generally used for those who are smokers, but having it as well for non-smokers is helpful. AI has been an interesting development at using that AI-assisted CT analysis has been very valuable, increasing the diagnostic sensitivity to 95%. And then the immunotherapy, we now have advanced immunotherapy that has been effective at treating some cancers along with chemotherapy. And we like to think that the surgery and radiation are less invasive, although we do more lobectomies and segmentectomies than we do lobectomies and pneumonectomies. We even have sleeve resections where she got a small segment of the lung and the bronchus. And then the stereotactic radiation that can be used to minimize the amount of radiation that is required to treat the cancer. And then once again, the genomic profiling, which will allow them to devise specific immunotherapy for your particular cancer. So these are things that are important to be aware of with lung cancer. So the bottom line is an early diagnosis is probably the best thing we can do, because we can then identify the least invasive therapy that can be used to cure the lung cancer. The later it's picked up, the less likely are the options for treatment. Any comments or questions about lung cancer? I'm sure all of us have had relatives or friends who've had lung cancer.
No question, Dr. Callender, but good morning and good morning to all.
Hi, Elizabeth.
It's my friends and fellow members at Washington Senior Wellness Center. We're glad to be able to catch you on this session. And our time for the session for this session today has ended. So we want to say goodbye and thank you so much for everything.
Elizabeth,
Yes, dear.
Thank you
Yes,
for
Miss
doing.
Sue.
yes.
Yes, Miss Sue.
I
Thank you
just
for.
want to let you know if you're taking the role, I'm on.
Yes, Miss Sue. Thank you.
Okay. Thank you. How many are with you today? How many are with you today?
Uh, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 27, 28, 29, 29.
Wow.
Whee.
My goodness. Well, thank you for joining us.
Okay, all right. See you next time.
Okay. Bye-bye. If there are no more questions or comments, we'll go to the next article. We've talked about these forever chemicals, as they PFAS is the term that they use for forever chemicals. And we know that they affect many diseases, but type 2 diabetes, much of the data is that 31% more likely to develop diabetes with exposure. The problem is that so many of us are exposed that this may just be the tip of the iceberg. Uh, but anyway, it's important to know that we got to do more work with the forever chemicals to find ways of decreasing their penetration to all of us. And we've talked about the fact that while we know about these forever chemicals, we aren't really that great at identifying how we're going to improve or decrease our exposure to these chemicals. And I guess one of the ways is to, since it's everywhere and with everything, uh, uh, and the more we use the plastics and other things, since they're found in blood of 98% of people in the United States. So the question is, it's not a matter of prevention. It's a matter of identifying what we can do to overcome the consequences. And I guess we all bought into the beauty of the plastics and non-sticking and all of that. And now we find out that it's everywhere and in everything. And what are we going to do about it? And that's the question. We talk about many things, but uh, we don't really. You talk about avoiding it, but it's kind of too late to avoid it. The question is, uh, since we're already exposed, uh, what kind of treatment is there to overcome it? And this is a question that hasn't been addressed adequately yet. Any comments, question about this topic that we talk about, but we don't really talk about resolution or remediation? Uh, any comments or questions? John Buchanan.
Yes, Dr. Callender, where do these chemicals end up when they're in our bodies? Are they in our liver or
They are,
lungs or
they're
brain?
probably in all of the tissues.
So once we get them, that's it. There's nothing we can do to get rid of them.
Right now, I don't know of any technology that has been proposed to eliminate them. When we talk about reducing exposure, we kind of talk about reducing exposure after it's affected 98% of the population. So it's kind of late. So what we really need to be talking about is, yes, if you can reduce exposure, and if you can't reduce exposure, what then? And that's the point that very few of the articles really talk about. And let's hope that in the future we'll have some articles which deal with, now that you're exposed to these forever chemicals, here's what you can do. So far, that is lacking in terms of articles.
Daryl's hand is raised.
Okay, Darryl.
Okay, the forever chemicals, they're used to make products grease-proof, waterproof, stick-proof, and stain-resistant. And so some of the typical sources are food packaging, pizza boxes, food wrappers, takeout containers, microwave popcorn bags, disposable trays, bakery bags. Okay, that microwave popcorn bag, that could be a favorite for some of you. Non-stick pans, the Teflon stuff.
Yeah.
I'm a After this group session, I'm about to go up and cook breakfast with a Teflon pan. Until I throw it out, I guess this afternoon. Uh, Carpets, you got a lot of stain-free carpets, carpets, rugs, furniture, textiles, window treatments, umbrellas, personal care products like dental floss, mascara, foundation, menstrual underwear, medical equipment, and masks. So I guess there's some PFAS in our masks that we wear to protect against COVID. Oh,
Frightening, frightening. Kind of emphasizes my point that we really need to have some efforts to overcome it. It's just it's kind of late for us to be avoiding it because we've already been exposed. So the next step is to find ways to treat it. Just say everything. Yeah. 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 Okay. Let's go to the next article. Uh, we're talking about now doing a system that measures the left ventricular and systolic pressure. And this is a way to diagnose high risk heart failure earlier. And this is found in patients with diabetics, chronic kidney disease, and the earlier you can treat it, the more likely you are to keep patients from dying from it. But this problem is, while they've had 2,000 patients who they've measured it, it's not really, so far, it's not a test that is non-invasive. And so that any patient who is fatigued or short of breath or has swelling is can be tested for it. But the problem is that the symptoms are nonspecific, and many of the other non-invasive tests aren't really that helpful. They're proposed to be, but actually, when you look at BNP levels and other things, they sometimes correlate, sometimes they don't. Abnormal EKGs can be very nonspecific. And so making this available is something else. Echocardiography and cardiac cath is okay after you've made the diagnosis, but to find tools that could non-invasively measure this would be a major breakthrough, and that's what this system is designed to do. When would it become available, and how would one get your doctor to use it for you? I don't know the answer to that, but down the road, at least when more people are aware of it, this may well be something that helps make an earlier diagnosis of heart failure and allow for earlier treatment. But we're not there yet. Any comments about the heart failure and the fact that if you have shortness of breath, have early fatigue, easy tiring, or shortness of breath, or any of those things that, or any swelling of fingers, legs, feet. These are indications that you could have heart failure. And the more non-invasive tests we have that are able to look at the and diastolic pressure may be helpful. So when this test becomes more available, this may be a boon to, since heart disease is the #1 killer in the United States, this is important to us detect it as early as possible. Any questions or comments? If not, we'll go to atrial fibrillation. We talked about this last week, and also talked about the ablation of it, as well as why atrial fibrillation is important to diagnose, and what you can do about it. Is AFib dangerous? Yes. When you have a 5-fold increase in risk of stroke, threefold increase in heart failure, and twice the risk of dementia. That means it's very dangerous. And sometimes it's symptomatic, sometimes it isn't. And it's more commonly when you're between 60 and 80. But diabetes and hypertension are risks as well as alcohol use. Warning signs, heart palpitations may be a sign, it may not be. But it's if one of the things you do if you have heart palpitation, you get an EKG. An EKG would be diagnostic because palpitations, if you don't have AFib, is not anything to worry about. But if you do the EKG and you find you have atrial fib, then it's important to treat it. Sometimes fatigue and weakness may be the first sign, shortness of breath often, dizziness, lightheaded, chest pain, and then edema they don't have here. But swelling can be in another condition that may alert you to the fact that you've got atrial fibrillation. And 40% of the patients have no symptoms at all, which means you need to get an EKG as part of your physical to be sure that you don't have it. And if you have it, then of course, the treatment is to get it eliminated by ablation or be placed on blood thinners to prevent the likelihood of stroke and also to beta blockers to slow the heart rate. Darryl?
Yeah, all kind of ranges for AFib. Top of the list when you have the most AFib is when your heart's racing or pounding. But that's a very obvious symptom. You think something's wrong. Think your heart's going to pop out of your chest. Uh, but the minor thing that people dismiss is a feeling of lightheadedness. That's good chance that could be AFib. You don't feel your heart racing necessarily, but you do feel the lightheadedness. So there's apps that you can get for your if you have a smartwatch, and it's a very accurate for Apple for an Apple Watch. I think it's called the ECG app, and it's very accurate for diagnosing whether or not you have an AFib episode. So if you experiencing lightheadedness, it could be some other things. It could be reaction to um, amlodipine, a blood pressure medicine, but it could also be AFib. So any type of lightheadedness is worth checking out.
Right, an EKG will make the diagnosis. Any other comments or questions? This important disease that we face as you age. Any other comments or questions about AFib? Okay, let's go to the next.
How important it is for us to have it as a preventive device for smartwatches for people at risk. It's so in comparison to one emergency room visit. It should be something like we we need to have blood pressure cuffs and things of that nature available to the populations at risk.
Daryl, what's that app again? The name of the app you were talking about?
It comes on any Apple smartwatch. I know that.
What's the
Yeah,
name
let
of
me
the
find
app?
it on my watch, and then I'll chime in once I find it.
I think an EKG may well be part of your annual physical, but if not, if you have any of these symptoms, it's a diagnostic test that uh, will not miss the diagnosis.
on your Apple Watch, they call it an EKG or an ECG.
Same thing.
Correct.
Yeah,
Same thing.
on the Apple Watch.
Yeah, EKG. Yeah.
Yeah, I believe it's ECG, but I'm still looking
It's
it up.
EKG and ECG are the same thing.
Yeah, but I think
Cardi
that's the name of the app on the Apple
yeah.
Watch.
Yeah, either one will work.
Right. Mhm. Right. Because that's the gold standard for diagnosing AFib. Right. Okay, let's go to the next article. Unless there are more questions or comments. We talked about this the last time, but repetition is good. If the blood pressure remains at or above 130 over 80 after 3 to 6 months, then drug therapy of lifestyle changes, drug therapy is recommended. And of course, the lifestyle changes are exercise, dash diet, and so forth. And this says adults with hypertension, with kidney disease, etc., should start antihypertensive medication immediately. And high blood pressure and dementia seem to be so related that it's important to do all of these things to reduce your blood pressure. And then, of course, I think the one thing that we mentioned before, but you have to mention again, is that the amount of sodium intake should not exceed 1,500 milligrams per day, which is new because it used to be 2,000 milligrams, but they reduced it because uh, we often are sodium sensitive. This is one of the few articles that comes out boldly to say that you should not drink alcohol at all, because that's most people don't like to say that, but it's probably true. This is an interesting consideration that low-dose aspirin may help prevent preeclampsia, which uh, gets you into hypertension and makes you a good candidate for long-term hypertension. Low-dose aspirin has many benefits, it has many problems as well. Any comments? If not, let's go to the next article. This is just diabetes is so common and diabetic foot ulcers are so common that I included this uh, because it's important to treat diabetic foot ulcers before they get to the point where you get to lose your foot or lose your life, so that the uh, healing of diabetic ulcers is life-threatening. Not only may you lose your foot, but you may lose your life. And so getting treatment for uh, diabetic foot ulcers is very important. So many people start off the end of their life with a foot problem, foot infection, foot ulcer. And so if you don't really have a good podiatrist and see them periodically, uh, every 1 to 3 months, it can result in you losing your life. There's no such thing as a simple foot problem. Addressing your footwear is very important. Interesting. That's one of the people I'm going to see today is a podiatrist. So uh, it's important to uh, look at your feet and recognize them as a gateway to your health. Uh, and you can see here they talk about structured surveillance, prevention, and wearing the right shoes. Uh, and all this is important. Your hand is important, your feet are equally important. Uh, So, of course, the psychosocial support and lifestyle are important as well. Any comments or questions about this? Is uh, preserving your feet is the first step to preserving your life, and that's not an exaggeration. Okay,
Dr.
let's.
Callender, would you say that a diabetic should have a podiatrist as part of their healthcare team?
Mandatory, absolutely mandatory. Yes, absolutely. I think it's desirable, even if you're not even if you are not a diabetic, to have, as you age, having a podiatrist to look at your feet. It's a good idea. But if you're diabetic, it's mandatory.
And for my sisters, see your podiatrist before your pedicure.
Yeah, that goes without question. Right. Yeah. Okay, I think this will be the last uh, topic. Blood test detects ALS years before symptom onset. Of course, here's another question. Why do you want to know about it 10 to 15 years before you have it? I'm not sure. It's like uh, since we don't have a treatment for ALS, uh, why do you want to know 10 to 15 years before symptoms appear that you're going to have it? It's a good question. I'm not sure I know the answer. Maybe you can give me your thoughts. If you would you want to know that you're going to have ALS 15 years before you got it? Or would you rather want to know maybe a year or two before you got it? What are your thoughts out there? ALS is a condition that's not associated with any cures, uh, uh, and is at the end of the ALS, you're unable to do anything for yourself. You're wheelchair bound, and you're pretty much incapable of doing anything for yourself, and it becomes very debilitating. So, uh, Betty Blaylock said, "I wouldn't want to know until I got it." What are your thoughts out there, Dr. Perez?
A very good girlfriend of mine, we're about the same age. She just got the diagnosis following hip replacement.
Hmm.
And though I'm very concerned about her mental health, um, her daughter is totally freaked out.
Don't
Uh,
blame me.
and freaked out because she lives in LA, is trying to make arrangements to be closer. So, like everything, if we could, uh, we say it takes a village to raise a child. It takes a village for us to get through stuff, and sometimes we make different choices based upon what we think could be our future. And I read it's a novel. It's called Measure, and it would be, I like some of you. I listened to it on Audible, but the issue was placed that everybody at the age 21 got either a long string or a short string, which equaled the amount of life that they were given. And it was very interesting to see how people responded. with that information. Much of it could be transformational. I had patients who whose lifestyles, their whole life, developed a quality once they got the diagnosis that they had AIDS, not just HIV, that they had AIDS. So it's the same kind of question we talked about with sickle cell and things like that. If the information is available,
But it's not the same. ALS is the end of your life. I mean, AIDS, we have treatment for AIDS and for many other conditions. There's no treatment for ALS. There's no cure for ALS.
right? But knowing that you can,
And why do you need to know 10 to 15 years before you
man,
have?
I'm not saying 10 to 15 years, but I don't know.
Well, it's a good question.
I'm glad I'm not faced with it right now, but I am thinking about it. I remember questions little children asked me when they had cancer, and they said, "Dr. P, am I going to die today?" So I'm I'm just adding to the discussion. I'm glad I'm not faced with it. Um, but I'm gonna seek my center. Um,
Okay. Any other comments on this subject? Would you like to know if you were going to have ALS 10 to 15 years before, or maybe 1 to 2 years before, or would you rather not know at all?
Okay. My comment is that, in a lot of diseases, black folks win. We have the most of. But with ALS, white folks win. They have the most incidence of ALS. The disease course shows up differently from whites and blacks. For example, whites are more likely to experience muscle weakness in the limbs. For blacks, we're more likely to. Well, we'll get that, but in addition, we get twitching in the hands. We'll have more incidence of pneumonia, and so they find that ALS is a little harder to diagnose with normal protocols than they do for white folks. We're typically diagnosed later in life, while whites are diagnosed earlier in life.
Would you want to know 10 to 15 years ahead of time that you're going to develop ALS?
Well, I know that's going to be individual. For me, I'd like to know.
Okay, you're right. I wouldn't want to know because I don't, that's too much headway. Year or
Well,
two,
if I
maybe.
knew that I was going to fall apart in 15 years, um, that 15 years that I had before I fell apart, I would make that a good one.
Okay, very interesting question, comment that about this disease, just like Alzheimer's. Uh, when you have diseases for which there is no treatment, this is what makes this different, is that Alzheimer's, there's no official treatment, and ALS, there's no treatment, no cure, rather. And so,
today.
well, we're talking about today, right? Yeah.
Well,
There's,
that was it. Like you said, that you used AIDS. At the beginning of the epidemic for Black women, it was diagnosis to death was
right,
six
right.
months.
Yeah, that's true, but now ALS is in that category, except that it's like Alzheimer's. That's the equivalent today, and we don't have a treatment for it. So, what's the point of knowing 15 years ahead of time? I can see, as Dal said, uh, anticipating death that long is something you should do anyway, and I would think. And so, living your life to the fullest is probably why people who have had chronic illnesses, make maybe they can live longer than other people because they are preparing for death all the time. So there's a positive side of it. So it's an individual decision, as you mentioned. And so, but it's food for thought. Any other comments?
Yes,
Dr. Callender?
yes, I have a comment. I would like to know ahead of time because I would govern my life and differently if I knew that information. You know, like now, if you look at the situation and you haven't discovered that you're going to die eventually, you would govern your life one way, but if you knew you were going to die, you would govern your life another way.
Well, we're all going to die. We're all going to die.
Yeah, we're all going to die, but the key is that you are going to govern your life differently.
Well, I guess that's an individual decision again. You're right, because we're all dying. All of us are dying. So we should always be preparing for death. So, but anyway, that's why I put the subject out there because it's something that all of us have to prepare for: ALS, death, and everything else. Any other comments? Interesting topic.
Dr. Callender, I was thinking, sometimes we've been faced with that, but if I know that, like if I was getting Alzheimer's or something, I would make provision for my care, who's going to be my caregiver, or what place do I go if I go into a stage where I'm unable to do something to make those decisions then. Just like you prepare patients, they're going to have a transplant, and we knew that you might end up passing before you make, or you might have your transplant in a certain vicinity. Like we thought at one time we were going to have it in Pittsburgh, so we made arrangements what we would do if we had to go to Pittsburgh and live for 6 months or something. There are just certain things you would want to do in preparation rather than wait till it happens and then you're left to the discretion of other people taking charge of your life and making decisions on how to care for you. If you say you would want to go to a certain nursing home or you want to go and live with this child or that child, while you're still able to make those decisions and that child is agreeing, then you would make those arrangements and everybody will be one accord of what you're going to do if when this happens or if it happens. And that's why I would want to know, well, maybe 2 years, 3 years, or even 10. I like to plan. If I know something's might happen or getting ready to happen, I'm a planner, so it won't just come upon me and I'll be unprepared, or my
Yeah.
family will be unprepared to um, discover and to put that on them all of a sudden. You just all of a sudden, and they didn't even know, or they could have helped, or something like that. They feel useless if you keep this hidden from them, or it's hidden from you, and you did no preparation.
Right. And then the question is 10 to 15 years versus 1 to 2 years. And so that's food for thought. And it's interesting to hear that. Any other comments? If not, we'll close with the discussion on this interesting topic of ALS and actually preparing yourself for the future, which we are all have to prepare for anyway. So, okay, any closing comments from any of you as we uh, look forward to next week? I guess we've had a record attendance today, huh, John Buchanan?
Awesome. Awesome group today.
Okay. All right. Well, I'm going to be in Cincinnati next week, but I'll be